In another 1 minute, sir, we are about to start.
Okay.
It's sharp 5 p.m., sir. So, with all your due permission, we are beginning with the session for today. Good evening, everyone. This is Batu from ITCPD, moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction at our platform, but yet it's great pleasure and honor to introduce him. He's none other than the very renowned cardiopulmonologist, Dr. Dipanjan Chatterjee, sir. Sir is MBBS, MD, FNB in cardiac anesthesia, FECMO, Director and ECMO and Transplant Program, Heart and Lung, and HOD of Cardiopulmonary Critical Care. With such wonderful insights, we are going to talk about the topic for today, which is ECPR, Future of Approaching Cardiac Arrest. So now, without taking much time and now without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Yeah. So why do you want to study about ECPR? We have all been knowing that a cardiac arrest may become a terminal event. And if we do not treat the patient immediately, we most likely would like to lose this patient. Even with our best efforts, we will be able to save some of the patients in the witnessed arrest. And outside the hospital arrest, in the Indian scenario, the outcome is pretty bleak. But this whole scenario is undergoing a huge change. And what are the new concepts coming up? How we can improve the outcomes of cardiac arrest? That is a matter which is being studied and practiced in many of the centers. So let us go and learn how we can improve the outcomes of cardiac arrest. Let me share my slides. Hope the slides are visible.
Yes, sir, it is. Please continue.
Yeah. So whether ECPR, that the concept that is coming up, is a myth or is it a hope for the patients as well as the physicians alike? That is what we are going to discuss. I have no significant disclosures except that I am an ECMO enthusiast and I believe that ECMO can save many patients. So if you have a patient of cardiac arrest, when you find the patient, what we start is a CPR, cardiopulmonary resuscitation, or what we are now calling it is a cardiopulmonary cerebral resuscitation, because the brain is the organ which shuts down first if there is no flow for a few minutes. And that is why we want the cerebral circulation to be maintained and till the time the heart improves the function and we obtain an ROSC, return of spontaneous circulation. That is our target of conventional CPR or CCPR in the next few slides that we will be seeing. So whenever we find the patient in cardiac arrest, diagnose it, and we start is CPR. That is the dictum that we have studied from our med school, continuing, and it has been almost same since the last quite a few years. So suppose you are not achieving an ROSC, there is no definite rhythm coming up, no hemodynamic improvement. How long are you going to continue CPR? So refractory CPR has been defined as CPR by where we with CPR for 30 minutes, there is no ROS. So after that, we usually discontinue the CPR and declare the patient. But if we do not get an ROSC, is it an end that we have practiced, or we have to think otherwise? The next thing that is important is good neurological outcome after cardiac arrest. And it has been found that most of the good neurological outcomes occur in the when we achieve a ROSC in the first few minutes of CPR. The more the duration of the CPR, the neurological or the functional outcome of after ROSC is not good. That means even if we achieve an ROSC after a very prolonged CPR, we will not get a patient who is neurological intact and with good organ function of the other organs. What has been found that if the most of the patients, that is 74% of the patients, there is ROSC, and most of these patients have a good neurological outcome within the first 9.3 minutes. And within the 16 minutes, maximum number of good functional outcome patients have already had an ROSC. Beyond this time, the outcomes are poor. So conventional resuscitation is most effective within the first 10 to 15 minutes, by which time more than 75 patients with good functional recovery have already achieved ROSC. And after this 15 minutes, the probability of good functional recovery, if we continue the CPR process, falls to only 2%. So that is very, very dismal. So repeating the same therapies, that is chest compression, adrenaline, intubation, ventilation, continuing the CPR cycle for more than 10 to 15 minutes is not giving us a good outcome for the patient. So this made people think otherwise, that how can we improve the outcome? Because the same thing, repeating the same thing again and again is not okay if it is not giving our satisfactory outcomes. So what is the survival of in-hospital cardiac arrest? That is the best scenario that we get. The patients are witnessed at arrest is at most 15 to 34% in various studies. For out of hospital cardiac arrest in the European systems, it is around 8%, so ranging from 0 to 18%. It's very, very dismal. So conventional CPR achieves only 25 to 30% of cardiac output. So when we are doing a chest compression, what we are achieving is of the net cardiac output the patient should have had, we are achieving only 25%. So only 1/4 cardiac output is going out. So this prolonging this period of conventional CPR, we will be carrying on with a low cardiac output state for a prolonged period, leading to progressively increasing tissue hypoxia. So this duration of conventional CPR, where we are going on doing a chest compression, is a low flow duration. Remember these words. So we are doing a conventional CPR, but the flow is not adequate. So we call this period as low flow duration. And before the start of conventional CPR, from the time of cardiac arrest to the start of conventional CPR, is a no flow situation where there was no output from the heart and the patient was or tissues were not getting any kind of circulation. So no flow duration and low flow duration, these are the two important criteria for choosing our patients for ECPR. So what is extracorporeal cardiopulmonary CPR, cardiopulmonary resuscitation, or ECPR that we call it, is the application of veno-arterial ECMO. What is veno-arterial ECMO? In ECMO, we have one pump, we have one oxygenator, we take out blood from a vein, large vein, usually from an IVC, and pass it through the pump and do the gaseous exchange in the membrane and give back that blood into the patient, into the arterial system. So we have a modified heart and lungs, a pump and a oxygenator, gaseous exchange medium. And this blood is going back to the arterial system to perfuse the tissues so that the tissues get oxygenated blood. So ECPR is the application of this system, the VA ECMO, in patients where conventional CPR measures are unsuccessful in achieving a sustained ROSC. Remember, we need to have a sustained ROSC. Otherwise, many times we get a rhythm, a few beats, and again the rhythm goes back to VT, VF, or asystole. Or even if we are having a rhythm, we are not getting adequate circulation. That is, the hemodynamics are very, very poor. So if we have such a situation where the conventional CPR is not being able to successfully achieve a proper ROSC, if there we can quickly insert the VA ECMO cannulas and put the patient on ECMO, we can get the system running and the tissue oxygenation, cerebral oxygenation, all can be maintained. So ECPR ensures there is sufficient organ perfusion, including that of the brain, and in patients who are without a proper ROSC with conventional CPR. So by providing this organ perfusion, it is providing time for delivery of interventions. Suppose you have the patient on VA ECMO. The heart has not started beating, but you have a tissue oxygenation going, cerebral oxygenation going. You can find out what is the cause of cardiac arrest, and then you can intervene. Suppose the patient had an acute MI, a left main thrombus, or an infarct, where you can treat, you can go to the cath lab, find out the cause, put in a stent, and get the circulation in the heart going soon, so that your circulation in the heart improves and the heart can start pumping again. So this time you wouldn't have got with the conventional CPR. With the conventional CPR going ongoing, no one will be able to adequately have a good diagnosis, proper diagnosis, shift to the cath lab, do the angiography and the angioplasty if needed. That is not possible. So this gives us a time for the interventions to trick in and for the heart to improve. So whenever there is a cardiac arrest, or if there is a profound cardiogenic shock, pre-arrest like situation, many patients are degenerating into, we can understand that in a few minutes the patient may be arresting, that the rhythm is degenerating, hemodynamics have gone down drastically. There, if you put the patient on VA ECMO and then wait for the outcome. What is the outcome that we want? One is, first and foremost, we want a good recovery. If there is good recovery of the heart, we can take off the patient from ECMO and continue the patient's own circulation with the own cardiac output. But if in certain instances, if we do not get a good recovery, then what? So we have to seek out whether this patient is a candidate for a heart transplant, or if the patient is not a candidate for a transplant, whether we can change from VA ECMO to a durable mechanical circulatory support. Remember, VA ECMO is a short-term mechanical circulatory support, which cannot run for a very prolonged period of time. So we have to either shift to a durable mechanical circulatory support or a transplant. But if neither of these are feasible, we have to take a decision whether to continue ECMO or to terminate ECMO, because this patient is not going to recover at all. This also is a probability. So ECPR can be in hospital, which can be an unexpected event for the patient, or if the patient is very sick, it may be a natural evolution of this acute critical illness. In those situations, we can do ECPR. But for out of hospital cardiac arrest, where we can do ECPR, it has to be a witnessed arrest, first and foremost. Not that prolonged period of arrest has occurred, we do not know, and the brain supply has been off for a prolonged period of time. We then go on to start ECPR. Maybe some patient, the heart will improve, but will end up with a vegetative neurological state. So witnessed arrest is the first and foremost. Second is that once the patient has had a witnessed arrest, bystander CPR should have been started within the first 5 minutes of cardiac arrest. And when we are doing a CPR, conventional CPR, the end tidal CO2 should be above 10. No flow time, that is the time from arrest to the start of CPR, should be less than 5 minutes. And the low flow time, that is the duration of CPR, should also be low. And we usually choose shockable rhythms, that is VT, VF, for our, these patients have a better outcome in ECPR. The first and foremost importance in ECPR is that your quality of conventional CPR should be very good. So the duration where we are having a low flow state, that is very well managed. Only then we will have a better outcome with ECPR. So invariably, the outcomes in out of hospital cardiac arrest is far, far lower than the in hospital cardiac arrest. And secondly, it has been found that what is the duration of CPR? If the duration is less than 20 minutes, we have a good outcome. But beyond the 20 minutes, the outcome starts to go down, down, down. It's very less chance that after 60 minutes, the patients will have a good outcome with good neurological outcome. But when it comes to ECPR, the mechanical CPR may not be allowing us for a prolonged period of conventional CPR, but ECPR, even after 60 minutes of arrest, we get good neurological outcomes in significant number of patients. Not very large, but significant. How ECPR helps? It helps by improving the cerebral circulation. So the duration of cerebral ischemia, the region of cerebral ischemia, they are all reduced. And because we are changing from a low flow state from conventional CPR to a good flow from the ECMO circuit. We have a good flow to the cerebral blood vessels, and the region of ischemia is much more less. It reduces the chances of reperfusion injury, and we have a much better neurological outcome with ECPR than with a prolonged conventional CPR. So till date, there has been 3 randomized trials for patients of out of hospital cardiac arrest. You can see that the low flow duration is significantly high. So the patient was having a cardiac arrest. He was started a conventional CPR, shifted to the hospital, and then put on ECMO. So the duration of this low flow is significantly high. And the higher the duration of low flow, the lower is the outcome. So most of these trials, except the arrest trial, have not given us any indication that ECPR is better than conventional CPR. But these are all with the ECPR in the out of hospital cardiac arrest scenario. So the routine cardiac arrest scenario, we have a initial cardiac arrest at the time 0. So by 5 minutes, there should be someone who has started the conventional CPR. So it is the no flow duration. If it is more than 5 minutes, the outcomes are very bad. If we have a CPR started within first 5 minutes, we try to achieve ROSC in the next 5 to 10 minutes. So by 10 to 15 minutes, we continue CPR. The longer the CPR duration, the less chance is the good outcome. So if by 10 minutes, we are not getting a good outcome, we call for the ECMO team. If the ECMO team arrives in the scene and starts cannulation, it takes a few minutes for cannulation, and the patient is put on ECMO as soon as possible. The neurological recovery is best if it is done within the first 15, if the ROSC is there or the circulation is established the first 15 minutes. And if there is no flow or low flow for the first 60 minutes and we have not been able to cannulate the patient and go on ECMO, we usually abandon the process, because after 60 minutes of cardiac arrest, we will not get a good outcome for these patients. So, whenever we are going for an ECPR, what expectations do we have? It's that the overall survival is quite poor. Still, we are going for an ECPR. Okay. Try to do we check whether the CPR has started within the first 5 minutes or no. So there is no flow state of less than 5 minutes. Whether there is earlier ROSC within the first 15 minutes, if not, then we should go for ECPR. Because after first 15 minutes, the neurological recovery with conventional CPR is not good. And what are the unfavorable causes of ECPR? If we are putting the patient on ECPR, the unfavorable situations may be the patient is old age, patient is having a malignancy, the lactate has already risen quite a bit. Those situations we are not getting a good outcome. But our target is to have early ECPR. So within the 20 minutes or 25 minutes time, we put the patient on ECMO. And if the patient has a shockable rhythm, that is VTVF, if there are signs of life, that is gasping, pupillary reflex is good, or movement of the limbs, these patients have a favorable outcome. ECPR has many things which has to be taken care of, starting from patient selection. Which patients should they select? Which shouldn't do? That you have to keep the criteria proper. When should we transit to ECPR? This is the thing that is the most difficult part in the in-hospital cardiac arrest, because we are all trained to continue CPR for 20, 25, 30 minutes and then say that it's not possible. Or call after 30 minutes, you are giving a call to the ECMO team. That will not solve the problem. The call to CPR team has to be given within the first 10 minutes. They will take some time to come, and you have to assess, do the consenting within a few minutes and jump onto cannulation and go for ECMO. So there is not much time for the ECPR team to work. So they have to be called in early. You have to have proper logistics there within the hospital system. There are many complications because ECPR, we are cannulating the patient in an emergency process. It's an emergency procedure, and that can lead to many complications. And your staff should all be trained so that at the time of ECPR, everyone knows his or her own role. And after that, you also have a lot of ethical issues. The first thing that we are told by the relatives is that the patient had already died, sir, but you continued the patient on a machine just to extract more money. So that is a very problematic situation in the Indian scenario. But if you can show them that the patient is getting awake, if the patient is having signs of life, then they will be a little bit you will be in a much safer zone. And also, if the ECPR, you put the patient on ECPR, how long to continue the ECPR with the ECMO? When we should call it a day? That if the heart is not recovering, how long? Those are all ethical issues that are there. And sometimes we have patients whose hearts improve. Definitely, we can come off the ECMO. But then neurologically, they are devastated. So they have a big stroke. They are vegetative. They are ventilator dependent. Their heart may have improved. But now we have created a patient who we have to care for a prolonged period of time. The relatives cannot let go. And they will always say that we cannot pay further. So what then? Coming to the selection of patients, which kind of patients we usually choose? We usually choose patients who are younger in age group, at least less than 70. The arrest should be witnessed arrest. The first CPR should have been started within less than 5 minutes. The patient should have an initial rhythm of VT-VF or pulseless electrical activity. Usually, the outcome in the asystole group is not that great. So, from the start of arrest to the start of ECMO flow, that is, low flow interval should be less than 60 minutes. And during the CPR, the conventional CPR, the adequacy of CPR is measured by the EtCO2 levels, and it should be more than 10. It is good that if the patient is returning back to ROSC or a stable rhythm for some time before again going back into the cardiac arrest. If the patient has signs of life, that is movement or gasping or something like that, that is also a good prediction that our patients may be neurologically intact. And if we put the patient on ECPR, the outcome may be good. And also, if there is absence of comorbidities, suppose the patient has a bad renal failure, bad hepatic failure, has had already neurological problems, is a patient of malignancy where life expectancy is less than 6 months. Then on those situations, we usually avoid going for it. And say, last but not the least, there should not be any aortic dissection, which is the cause of our cardiac arrest, and our aortic valve should not be incompetent. So when we have a CPR, we alert the ECMO team if there is no ROSC within the first 10 minutes. The ECMO team comes and starts assessing the patient and setting up of the ECMO systems. And another team goes to the patient and discusses the situation and takes the consent to, if you are in a corporate or a private setup, you also have to tell about the cost involved. Once everything is set in, you start off cannulation, put the patient on ECMO after cannulation and optimize the flow of ECMO. Have adequate clearance of lactate, good tissue perfusion, do an AVG, check the electrolytes. If we have an ROSC in this time, then we have to continue our ECMO flow, but shift the patient to the cath lab and see what is the problem going on there. Also assess the hemodynamics. If the patient is having, with every ECG lead, you have one arterial beat. That is, you are having a pulse with every ECG, with every cardiac electrical activity, you are having a mechanical activity. Then we have to wait. But if the patient is not having a good pulse, that is, we are not getting any cardiac contractility and aortic valve is not opening, we have to go for LV decompression. What are the complications of ECPR? Mainly, all the complications of VA can occur in ECPR, starting from bleeding, hemolysis, or clot formation within the circuit, or also it can be clot formation within the low flow sites within the heart or the proximal aorta. There can be sepsis, LV distension can occur, leading to further jeopardizing of the heart, and also there can be secondary reperfusion injuries, hyperoxia-induced endothelial dysfunctions. All these can happen, and stroke. The most important problem in ECPR in the Indian context is the financial constraint. In the Western world, both in-hospital and out-hospital cardiac arrests are usually funded by the governments. But in the developing country like ours, the out-of-hospital cardiac arrest is still a dream for us. Though in-hospital cardiac arrest, we have started to put the patients on ECPR after initial financial discussion with the family. We always have to say that the outcome may not be good, but obviously we should give a try. If the patient is young, patient did not have any comorbidities previously, had a good lifestyle. So in those situations, we obviously should go and try for ECPR. So post ECPR, you may have a patient who is neurologically, he has gone down with stroke. There has been irreversible damage. What will you do? Many times we explain to the relatives and withdraw the ECMO. Or else, if the patient is a young, the other organs are well perfused and functioning, this patient, you can explain the relatives and go for an organ donation. So he may not be living, but his organs can be taken by other deserving people and live in them as organs. If the patient is not improving cardiac-wise, then we have to go for, again, transplant or durable mechanical circulatory support. Or if the patient will not recover and the relatives are not willing for either of these, then we have to go for withdrawal. Patients may also end up in multi-organ failures, maybe because of sepsis. He can have a recovery, but the recovery may be marred by a lot of complications. So these patients will have poor quality of life after discharge. And finally, what is most important and what is our target is that recovery with intact organ functions. Extracorporeal versus conventional CPR, if we compare, do we have an actual comparison? But it's only a meta-analysis. So that has shown that compared to the conventional CPR, we have ECPR can have a reduced in-hospital mortality. And long-term outcome also can be good with ECPR. What is the outcome of ECPR? In the adults, the outcome has, according to the ELSO registry, which is the apex body which keeps all the outcomes recorded. For ECPR, it is 30% in the adults compared to the VA or VV ECMOs, which may be around 46 to 58% recovery chances. The pediatric, the outcomes are much better, 41%, and neonates, even neonates ECPR has been done, which is 43% outcome. So can we have a guideline where once we put the patient on ECMO, at that point of time, we can prognosticate the relatives whether the patient's outcome is good or not. It is difficult, but this rescue score is there, which can show us that what are the chances of our survival. And it includes pre-ECPR modalities, that is, what was the low flow time, what was the no flow time, and what is the cause of this cardiac arrest, what is the age of the patient, and whether the patient has any second organ damage or not, whether the patient has had a previous renal dysfunction, previous hepatic dysfunctions. All those are, and secondly, just হ্যালো, আপনাকে একটু 5 মিনিট পর ফোন করছি, ঠিক আছে? So actually, if we can combine these and how long we took to cannulate the patient, put the patient on ECPR, if we can keep that on minimum, we may have a better neurological outcome and functional outcome in ECPR. It is difficult to cannulate the patients when the CPR situation is going on, because you are getting a constant chest compression. The cannulating the femoral vessels, the femoral artery and femoral vein will take time. And if it is a blind procedure, you may fail. So always try to cannulate with the ultrasound if you have. And once the patient you have cannulated, you put the patient on ECMO. So whether this ECMO backup helps us in any way in a center when you are going to start an ECMO program, how does it help? In what help does it give to the other specialties? So there was a 59-year-old gentleman with cough, low-grade fever for 2 months and distress for 2 weeks. Patient had a stridor, decreased air entry in both the lungs. CT thorax showed that there is a space occupant lesion in the right hilar region in the trachea with mediastinal lymphadenopathy. There was a mass and the pulmonologist wanted to do a check bronchoscopy and a biopsy. So this was the plan. But once the patient, they had taken a biopsy, there was bleeding, and that bleeding resulted in clotting, and clots clogged both the bronchi. Now, when the patient was intubated also because of the hypoxia that was ongoing, the anesthesiologist couldn't ventilate the patient because no air will go in because there are clots. And because of increased bleeding, the pulmonologist could not suck out all the things. The patient landed up in cardiac arrest. So, if we, in a situation like this, however much you go on doing a conventional CPR, the patient is not going to revive. So, we put the patient on ECMO immediately. We were called in. Usual cannulation time is 10 to 12 minutes in most of these patients, and the patient was on ECMO within 20 minutes after the call. So around 32 minutes of post-arrest, we had gone on ECMO. So after that, we checked the cardiac function. It improved, and we changed over from a VA to VV ECMO. So once the LV function was better, we changed over to VV ECMO because we wouldn't be able to ventilate the patient. The VV ECMO will help us in gaseous exchange. And after the lung recovery, the clots were removed, we could take out the VV ECMO. When we are taking out the clots, because of the mass, we had put in a stent in there. You can see that both the bronchi are open and can be seen. So ECPR obviously gives us a second chance at life. So where you are failing with a conventional CPR, ECPR comes to the rescue and gives us a second chance of life. Thank you all. Thanks from Medica ECMO team. Anyone who is willing to learn ECMO, we almost always have 1 or 2 patients on ECMO going on, and you can come over and we can all show you how we do these kind of patients. Thank you very much.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and sharing such wonderful insights with a nice presentation that you have shared. And I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us. We have received 2 questions from the participants. So with all your due permission, I would like to put across those questions to you.
Please.
So the first question is related to mechanism. So what mechanism should be in place for continuous monitoring and quality improvement of ECPR practices?
See, how we quantify the efficacy of our ECPR practice. First and the foremost thing is that how soon the ECMO team can reach the patient and how soon the conventional CPR team gives a call for ECPR team, the ECMO team. The main problem comes in where the call comes in late. And then you jump, go, and if we take more time for cannulation, that window of 60 minutes is gone, and putting the patient on ECMO after that will not get a good outcome. So how soon we are calling the ECMO team, how soon we are converting the patient from a low flow state of conventional CPR to a stable ECMO flow. That from arrest to initiation of ECMO time, if we can minimize it, that will give us a better outcome. So that is another variable. Third variable is cannulating without a vascular injury, because that is a time where the vascular injuries occur most. And if we have a vascular injury, these patients almost invariably, it's very difficult to manage. Outcomes are bleak. Fourth thing is that once you have put the patient on ECMO, do not forget to keep the temperature a little bit lower for the first 24 to 48 hours, because a therapeutic hypothermia in these patients have been shown to have a better neurological outcome. Finally, change over how fast you can wean the patient, depending on how quickly the patient's cardiac function improves. You can wean the patient from ECMO. That is another variable that will give us a good long-term outcome. So all these things we have to keep in mind.
Thank you so much, sir. Thank you. And with this, we would like to conclude the session here for today. Until next time. And I would like to thank all our viewers for their ardent participation that they have shown by staying tuned with us. And I would like to thank you, sir, for taking out your valuable time and for being here and sharing such wonderful insights on and sharing that representation and making the viewers understand. We hope that this is definitely going to help them in their clinical practice of their daily lives. Thank you so much, sir. So with
Thank
this,
you.